the fifth meeting of the House of Commons Standing Committee on Justice and Human Rights as we continue to study Bill C-7. Today's meeting is taking place in a hybrid format. I understand that there are a number of members that are in the committee room at this time, and the proceedings that will be made available via the House of Commons website. Just so you're aware, the webcast will only show the person that is speaking instead of the entirety of the committee room. To ensure an orderly meeting, I'd like to outline a few rules below. Members and witnesses may speak in your official languages of your choice. Interpretation services are available for this meeting. You have the choice at the bottom of your screen. If you see interpretation, you can select either the floor language, English, or French for your translation or interpretation. For members participating in person, proceed as you usually would when the whole committee is meeting in person in the committee room. Just keep in mind to keep masking and health protocol rules as a priority as you attend in person. Before speaking for the witnesses and for the members, please wait until I recognize you by name. For those participating virtually, please click on the microphone icon to unmute yourself. Those in the room, the microphone will be controlled as normal by the Proceedings and Verification Officer. As a reminder, all comments by members and witnesses should be addressed through the chair. When speaking, please speak slowly and clearly. When you are not speaking, your mic should be on mute. And with respect to keeping the dialogue respectful and engaging, it's okay to disagree, but it's not okay to be disrespectful to one another. With regard to the speaking list, the committee clerk and I will do the best that we can to maintain a consolidated order of speaking for all the members, whether they're participating virtually or in person. So I'd like to welcome now our witnesses below, which are 4 organizations that are represented by various esteemed guests. So we have the Canadian Association of MAID Assessors and Providers, represented by Dr. Stephanie Green, who is the president. We have the Canadian Medical Association, represented by Dr. Anne Collins, who is the president, and Dr. Cécile Ben-Simon, Director of Ethics and Professional Affairs. We also have with us the Commission on End-of-Life Care, represented by Dr. Michel Bourreau, Dr. David Lucier, Pierre Deschamps, and Stephanie Goulet. We also have the Maynard Martin Avocat, represented by Jean-Pierre Marnad himself. So each of these 4 organizations will have 5 minutes to make your opening statements, followed by rounds of questions. I'll invite the Canadian Association of MAID Assessors and Providers to please begin with 5 minutes on the clock. Thank you. The floor is yours.
Thank you. Thank you for the opportunity to be here today. My name is Stephanie Green, and I'm a physician with 25 years of clinical experience. In June 2016, I began working almost exclusively in medical assistance in dying, and I'm currently an assessor of eligibility as well as a provider of MAID in Victoria, BC. While I wear a number of MAID-related titles, I'm primarily here today in my capacity as the president of the Canadian Association of MAID Assessors and Providers, a national medical association that represents and supports the variety of professionals who've arguably grown into the foremost experts of assisted dying in this country. I wish to impress upon this committee that as an organization, we do not work to advocate for assisted dying. We are, in fact, the community of professionals that do the work to the highest of medical standards and always within the law of the country, whatever that law may be. We have the collective lived experience of how the practice of assisted dying has unfolded across this country, where the obstacles and successes have been found, and how the system might be improved to the benefit of all involved. It is in this context that I now address you and hope to answer your questions. In the limited time I have, I want to be sure to first emphasize what I think Bill C-7 has gotten right, what I think needs clarification, and suggest 2 simple but practically important changes. I first want to support the proposed removal of the 10-day reflection period for those whose death is reasonably foreseeable. In 4.5 years, there has been no evidence this reflection period has safeguarded anyone from anything, but there is evidence to suggest it has mandated substantial suffering which I do not believe was the intention of the law. In my written brief, I have provided some of this convincing data, and in my comments now, I simply bid good riddance to what has proven to be an essentially false safeguard. Secondly, I want to strongly support the proposed amendment to allow the waiving of final consent in the specific situation outlined in Bill C7. A 2019 survey of MAID providers suggested 85% of providers have personally experienced the situation of walking into a room to facilitate an assisted death, only to find the patient no longer able to provide final consent due to an unexpected loss of capacity. I can tell you from firsthand experience how horrible that situation is. Loved ones standardly beg for the clinician to proceed. It is an agonizing situation for all, and I'm unable to appreciate who exactly is being protected in such a situation by not proceeding with the previously planned MAID death. I am absolutely clear on who is harmed. The proposed amendment is essential, overdue, and will be welcomed by patients, their families, and the professionals involved in this work. I do find the proposed requirement of setting a specific date somewhat problematic from a practical point of view. In my written brief, I've suggested a 90-day timeframe be used instead of a specific date being set, and I've suggested some very simple altered wording for your consideration. Thirdly, I applaud the government for specifically using the term expert when seeking expertise in complex illnesses and patients whose deaths are not reasonably foreseeable. This is a recognition that one does not need to be a particular medical subspecialist to have expertise in illness. Very often, family physicians and nurse practitioners are, by nature of their practices, experts in a wide array of illness. This is especially true of practitioners in rural communities. In fact, many types of health professionals can and do develop expertise in specific illness, and it is wise to recognize this wide range of possible expertise. That being said, there are two remaining issues that must be highlighted. Firstly, I need to point to what I believe is a small but tremendously important error in Bill C7 that suggests a misunderstanding of healthcare realities and carries significant ramification. I believe this error can be easily and consensually remedied. Current wording of subsection 3.1 suggests that a clinician with expertise in the illness must be one of the assessors of eligibility for MAID in patients whose death is not reasonably foreseeable. Requiring the input of an expert on the illness in such a situation is not an unreasonable requirement, but mandating that expert complete an assessment of eligibility for MAID itself is wholly unrealistic. As consultants consistently write in their reports to me, they will comment on their area of expertise, but respectfully decline to opine on a patient's overall eligibility for MAID, as that is neither their area of expertise or interest. In my written submission, I have suggested simple wording that maintains the requirement for expert input, but allows, in fact requires, two experienced MAID assessors to do the work of assessing the patient's eligibility for MAID. To do otherwise, as is currently written, will essentially obstruct access for MAID for those whose death is not reasonably foreseeable. And finally, the term reasonably foreseeable has historically created confusion. Now that a consistent clinical consensus has developed and we have court-backed working interpretation, it would be helpful if the government were to reinforce that the determination of what constitutes a reasonably foreseeable death is indeed a clinical decision and its meaning has not changed with the implementation of Bill C7. I'm happy to answer any questions on these or other issues, and I thank you for your serious consideration of my comments today.
Thank you very much, Dr. Green, for that. Really appreciated for keeping your marks within 5 minutes also. I think it's a great sign. Next, we have the Canadian Medical Association with Dr. Ann Collins and Dr. Cecile Ben-Simon. Your time starts. Your 5 minutes starts now. Please go ahead. You're on mute. My apologies.
Thank you, Madam Chair. It's my honor to appear before you today. I am Dr. Ann Collins. Over the past 3 decades practicing medicine, I have taught family medicine, run a family practice, served with the Canadian Armed Forces, and worked in nursing home care. Today, in my capacity as president of the Canadian Medical Association, I represent our 80,000 physician members. In studying Bill C7, it is incumbent upon us now to consider the effects on patients that the passing of this bill will have, but also the effects on the medical professionals who provide medical assistance in dying, MAID. When the original MAID legislation was developed as Bill C14, the CMA was a leading stakeholder. We have continued that commitment with Bill C7. Having examined Bill C7, we know that in a myriad of ways, The results of our extensive consultations with our members align with the findings of the government's roundtables. Fundamentally, the CMA supports the government's prudent and measured approach to responding to the Truchon-Gladue decision. This thoughtful and staged process undertaken by the government is consistent with the CMA's position for a balanced approach to MAID. Nicole Gladue, whose name is now inextricably tied to the decision, spoke as pointedly as perhaps anyone could when she affirmed that it is up to people like her, and I quote, to decide if we prefer the quality of life to the quantity of life. Not everyone may agree with this sentiment, but few can argue that it is a powerful reminder of the real stakeholders when it comes to considerations of this bill. This applies just as critically to those who are currently MAID providers and those who will become providers. They are our members, but we can't lose sight of the fact that we must all support both patients and providers. Through our consultations, we learned that many physicians felt that clarity was lacking. Recent federal efforts to provide greater clarity for physicians are exceedingly welcome. The CMA is pleased to see new non-legislative measures lending more consistency to the delivery of MAID across the country. The quality and availability of palliative care, mental health care, care for those suffering from chronic illness, and persons with disabilities to ensure that patients have access to other appropriate healthcare services is crucial. The CMA holds firm on our convictions on MAID from Bill C-14 to C-7. We believe, firstly, that the choice of those Canadians who are eligible should be respected. Secondly, we must protect the rights of vulnerable Canadians. This demands strict attention to safeguards. And lastly, an environment must exist that insists practitioners abide by their moral commitments. These three tenets remain equally valid. Our consultations with members demonstrate strong support for allowing advance requests by eligible patients who may lose capacity before MAID can be provided. The CMA believes in the importance of safeguards to protect the rights of vulnerable Canadians and those who are eligible to seek MAID. The CMA also supports expanding data collection to provide a more thorough account of MAID in Canada. However, this effort must not create an undue administrative burden on physicians. The CMA views the language in the bill, which explicitly excludes mental illness from being considered an illness, disease, or disability, problematic, and has the potential to be stigmatizing to those living with a mental illness. We trust that Parliament will carefully consider the specific language used in the bill. Finally, the CMA endorses the government's staged approach to carefully examine more complex issues. However, we must move forward to ensure practitioners are given the tools that will be required to safely administer MAID on a wider spectrum, such as support for developing clinical practice guidelines which aid physicians in exercising sound clinical judgment. Such guidance would also serve to reinforce consistency in the application of the legal criteria. In conclusion, Madam Chair, allow me to thank the committee for the invitation to participate in today's proceedings and to share the perspective of Canada's physicians. The pursuit of a painless and dignified end of life is a noble one. The assurance that the providers of this privilege are supported is an ethical imperative.
Thank you very much, Dr. Collins, for that. We'll next move to the Commission on End-of-Life Care. So please go ahead. Your time starts now.
Madam Chair, parliamentarians, as President of the Commission on End-of-Life Care in Quebec, accompanied by the Commissioners Mr. Pierre Deschamps and Dr. David Lucie and the Secretary General, Madame Stéphanie Goulet, we would like to thank you very much for this invitation. Since the 10th of December 2015, the Commission in Quebec has examined the reports from almost 6,000 MAID administered in Quebec, and we've been able to draw several lessons from this. And today we're going to talk about the data related to 5 main objectives under Bill C7, but we'll not talk about MAID for mental disorders or people that are incapacitated, because we do not have any data on these subjects. We will deal with 5 subjects. First of all, we support the withdrawal of the criterion for reasonably foreseeable natural death. If it's adopted, Bill C7 will allow access to MAID for several people who are suffering from an illness or disability or another serious and incurable illness, who may have years or decades to live and suffer from their condition. And the Commission believes that the withdrawal of this criterion will not cause a significant increase in requests for MAID, nor will it lead to death on demand. Secondly, the Commission approves the elimination of the 10 days waiting period before administering MAID. According to the data that's been transmitted to the Commission, this delay of 10 years between the request and the administration of MAID represents a period of great suffering for people and their next of kin. In fact, more than half, that is 53% of people receive MAID within 10 years after having made this request, not just because they're afraid that they will lose their capacity to consent.
I can hear the interpreters are rushing quite quickly to try to catch up to you. It's okay to slow down just a little bit so everybody can understand the content of what you're saying. I'd appreciate that. Thank you. Please continue.
Thank you for your comment. In fact, 53% of people who receive MAID within 10 days because of big suffering or because they're afraid of losing their aptitude to consent. Thirdly, the Commission actually approves the waiver to final consent. Around a quarter of the forms, 26%, transmitted to the Commission, mentioned that the person refused the medication that was prescribed because they were afraid that they would lose their capacity to consent. And this leads to unnecessary suffering on the part of these people. Fourthly, the Commission also approves the fact that there are 2 different processes for assessing and having safeguard measures for MAID where there's natural death that's reasonably foreseeable or not. The Commission believes that the mechanisms of assessment and the current safeguard measures are adequate for the requests of MAID for people where natural death is reasonably foreseeable. The Commission agrees with the proposal in Bill C7 to establish a specific process to evaluate people and to have more safeguard measures for those people who ask for MAID where natural death is not reasonably foreseeable. Then a 5th point, the Commission recommends that for a safeguard measure, there should be an oversight and assessment committee that should be set up for all of the MAIDs that are administered. The National Assembly in Quebec decided to set up this type of mechanism and handed it over to our Commission, and we draw inspiration from Belgium and the Netherlands. If we increase admissibility to MAID for people where natural death is not reasonably foreseeable, and drawing on our 5 years of experience with more than 6,000 MAID analysed where the people's death was reasonably foreseeable, we can draw 3 conclusions. First of all provider of MAID has to make a report on the administration of MAID and should describe the complete clinical picture justifying this, and he should know that this will then be examined by experts. Secondly, the a posteriori analysis of each MAID will allow for immediate feedback from physicians and establishments to give explanations or to avoid any potential slippage, and it will also reassure the public. Thirdly, the Commission in real time is able to evaluate the MAID administered and to identify quickly new trends, having recourse to this practice where necessary. And I'd like to thank you for listening to us, and we will be handing over a brief that will give further details on our presentation. Thank you.
Merci à Dr. Bureau pour votre.
Thank you very much for your intervention and your engagement with our committee. Thank you very much. And now we'll turn to Mr. Jean-Pierre Mena for 5 minutes, please. Good morning, everyone. And we are very happy to be here this morning. I have had the opportunity of representing Mr. Truchon and Madame Gladue in the request that they made to the government, and in particular Mr. Truchon, who passed this year. And so I'm particularly happy to see the results of all of this. So I'm not going to come back on all of the points in the reform. I'd just like to group together certain elements. First of all, of course, we support everything that facilitates a MAID for people who need this. And the fact that we're eliminating the reasonably foreseeable death and the 10 days of waiting will simplify the process, and also the waiver to the final consent, that these are all elements that we very much approve. However, there are certain elements, in fact, there are two elements in the bill that are cause for concern. First of all, the notion of reasonably foreseeable natural death. The Superior Court of Quebec has dismissed this criterion as a criterion for being admissible for MAID, but it has even gone beyond this. This is a criterion that it's difficult to put into practice, and it doesn't mean much for physicians. So this is being withdrawn, but then it's being brought in to bring two separate approaches for those where death is not foreseeable, reasonably foreseeable. And then there's a second category of persons where they can have a different treatment from those in the first track where the death is reasonably foreseeable. And then there's another series of other formalities, including the 90 days waiting period. I don't know why that's in here. I do not think it's useful at all. And Justice Baudouin, in his ruling, pointed out that assessments should be carried out on a case-by-case basis, and a physician should assess people based on the merits of the case rather than having a grouped approach for people where death is not reasonably foreseeable, whether it's vulnerable persons or people who apparently counted less than others. So I support that this element is a derogatory one, and I set that out in my brief in more detail. And then the 90 days period that accompanies this, I would like to submit that it's not useful at all. For those who've asked for MAID and who meet the conditions should be able to obtain this right away and just respect the formalities that are set out in the legislation. And then turning to mental illness. In the bill, they're not considering mental illness as an illness that's admissible. Once again, Justice Baudouin clearly stipulated in his ruling that we should have a case-by-case approach depending on people's individual capacity rather than having a blanket approach with one category, because otherwise this opens the door to a great deal of discrimination and non-necessary stigmatization of those suffering from mental illness, and it can lead to other forms of abuse. And I think it can be very much challenged from a legal point of view. So we need to look at this correctly. For people where we believe that death is not reasonably foreseeable, and also what are we going to do with those who suffer from various mental illnesses. I've understood that in the bill, there's going to be subcategories created, which can certainly be challenged as non-constitutional. Otherwise, the bill has made some progress, but we have to make sure that we do not fall into these problematic areas that I have outlined. Thank you.
Merci, Monsieur Ménard.
Thank you, Mr. Ménard.
Go into our first round of questions. We'll start with Mr.
Nous passerons maintenant aux questions. 6 minutes, Monsieur Moore, s'il vous plaît. Vous avez la parole. Merci, Madame la Présidente.
Here, so that's better. Thank you, Madam Chair, and thank you to all of our witnesses for being here today. There's a multitude of opinions on this issue, but there's people of goodwill on all sides of the issue that want the best for Canadians. And Dr. Collins, it's good to see you again. I want to direct my first question to the Canadian Medical Association. I feel as a society, the true measure of a society is how we care for the most vulnerable. And as we've undertaken this study, I know I've been contacted, as have all members of this committee, about concerns for people that are at a low point in their life, people who've just heard about a major illness, and people that are the most vulnerable in our society. And one of the concerns that's been raised is, even though Bill C-14 was passed just a short time ago, and we still haven't had our parliamentary review of Bill C-14, the government did not appeal the Quebec Superior Court decision last year, and this bill, this response, pulls out a number of the safeguards that Parliament, in its wisdom, put in place just a few short years ago. So you mentioned in your brief that you circulated to us about the importance of ensuring vulnerable Canadians are adequately protected. We know of cases that have been publicized of people who clearly have been coerced to consider MAID, who didn't raise MAID, but have been approached to consider MAID. I find that concerning. So could you give some thoughts from the Canadian Medical Association's perspective on how we can ensure vulnerable Canadians are adequately protected?
Thank you for the question, and through you, Chair. The Canadian Medical Association feels it is important for all of us and for parliamentarians to consider the concerns and to respect the needs of vulnerable populations. We feel that safeguards should ensure that there's no undue influence on any patient, either those seeking MAID or those not. And so we have a responsibility, we believe, as physicians and as society, to make sure that all vulnerable Canadians have access to what they need for proper care. And that includes support for good mental health care, for the care that people with disabilities require, for people who have who live with chronic conditions, that they have the access to the proper care and support that they need.
Thank you for that. Now, the Canadian Medical Association has said that it's important that there be an environment where physicians can adhere to their moral commitments, that must be maintained. And we've heard just recently the committee circulated a letter with almost 800 signatures from physicians that are concerned about their conscience rights, that providing MAID, assisted dying, to under Bill C-7, someone who in fact is not dying, whose death is not reasonably foreseeable, they're concerned about the impact on their conscience rights. Can you provide thoughts from the Canadian Medical Association perspective on the importance of protecting conscience rights for medical professionals, doctors, nurses, etc.?
Thank you for the question, and again, through you, Madam Chair. Fundamentally, the CMA supports maintaining the balance between three equally legitimate considerations: respecting decisional autonomy for those eligible Canadians who are seeking access, protecting vulnerable persons through careful attention to safeguards, and creating an environment in which practitioners are able to adhere to their moral commitments. The CMA equally supports conscientious objection and conscientious participation. And although in surveys we have seen not consensus amongst our physician members, this is one area where there is continued high level of support for CMA's position.
Thank you. I think protecting vulnerable people and protecting the conscience rights of physicians is something that around this table we should all agree on. And I know we only have a couple seconds, but Bill C-14 required a parliamentary review. What role would you like the Canadian Medical Association to take in the process of that review, which was supposed to have already taken place?
Very briefly, Dr. Collins.
Yes, thank you, Madam Chair. I will just say briefly that the Canadian Medical Association looks forward in working together and providing what input and support that we can for a parliamentary review on these very complex issues.
Thank you very much. Thank you, Mr. Moore. We're now going to go to Mr. Maloney for 6 minutes, sir. Go ahead, your time starts now.
Thank you, Madam Chair. Let me add my thanks to all the witnesses for coming to help us discuss what's a very complicated but very important piece of legislation. Dr. Collins, I hate to pick on you again, but you said in your opening remarks that the CMA language in the bill, which explicitly excludes mental illness from being considered problematic, has a potential of stigmatizing those living with a mental illness. No one here will disagree with that. Stigmatizing those with mental illness is a significant concern, but in this context, with MAID, there's some dire consequences. Are you saying that you agree or disagree with the prohibition of mental illness as a sole ground for requesting MAID?
Thank you for that question, and through you, Madam Chair. Our comment is around the language that is used in the bill and its problem in that it does potentially stigmatize those living with mental illness. We recognize that this is another complex issue that will continue to be dealt with as we move through these legislative processes. And again, it is a complex issue that the Canadian Medical Association looks forward to working with and to provide or to seek clarity around this issue about eligibility.
Okay, we all agree it's a complex issue, but that means it requires an answer which hopefully isn't complex. So are you suggesting that there should be some cases where mental illness shouldn't be a barrier to MAID, or I'm just not clear on what you're saying?
Thank you for the question, and through you, Madam Chair. This is one of the areas when we survey our physician members where there is no consensus, and so it is an area in which I believe reflects what is heard at other tables, and so it is an area that requires further clarity and further review.
Okay, well, thank you. That which leads my next question. I mean, it's that lack of consensus, I think, is the reason this is in the bill. And
Si vous me permettez.
If I may, on that question, I would like to respond. Mr. Justice Baudouin, in his decision, said very clearly that in every case, the case must be discussed and decided on its own merits to see whether the criteria are met for medically assisted death. So there has to be an individual assessment as quickly as possible. I think that that is a way that we could proceed. We should not create another channel, a separate category.
Thank you, sir. That leads to my next question, really, because so as it stands, mental illness is prohibited, but it's not prohibited if it's in conjunction with another illness. And in my view, that may potentially lead to a problem, because if you've got a medical illness that does put you in a situation where you're eligible for MAID, but there's a mental illness component to it, you're still forced into that situation of having to assess the mental illness, which is the concern that gave rise to it being prohibited as a sole basis for requesting MAID. So I'm struggling with how you reconcile those two things, particularly in a scenario where you require a second opinion that's an expert opinion. If the expert opinion is on the non-mental illness issue, do you then require a third opinion regarding the mental illness issue?
I'm hoping that question's for me.
That's for all of you.
Perfect. I'm going to take the first opportunity to answer, and thank you for the question. Madam Chair, I would just like to point out what I'm sure is clear amongst most of our members, that mental health as a sole underlying condition is not explicitly prohibited against under Bill C-14. And in fact, there have been cases in this country of people with mental health illness as the only underlying condition going ahead, qualifying for and proceeding with MAID. Having said that, more commonly, because that's not commonly achievable with naturally foreseeable death, we don't see it very often, it is obviously much more common for us to have already seen patients with both mental health illnesses and physical illnesses applying for and being found eligible for MAID and proceeding. Of course, there's many people who, in that situation, it's up to the assessors and the providers to do the best job possible to ensure that capacity is still present, which mental capacity is always presumed to be present unless it isn't. So it's not uncommon in that situation for physicians and clinicians who all the time assess capacity in our patients every day in our offices for all medical treatments, for all surgical interventions, to be able to distinguish between the two.
Thank you, Dr. Green. That brings you at exactly 6 minutes. Mr. Maloney, thank you.
Thank you, Madam Chair.
Monsieur Thériault, voulez-vous commencer?
Mr. Thériault, do you want to start for 6 minutes? Mr. Thériault? Mr. Thériault, vous êtes...
Excusez-moi.
I'm sorry. Now I'm not on mute. There was a little bit of a problem with the sound. I first want to start with Mr. Ménard. If I understand correctly, you are saying that C7 could open the door as widely as C14 to complaints that there are charter violations against people's rights. Yes, because people may not meet the criteria. The criteria that should not be used for MAID, it depends on each situation. It should be done on a case-by-case basis by a doctor. The fact that there is a diagnosis for a certain condition, that is certainly one criteria to be met, but the person needs to understand what is involved and we need to take into account the whole situation. But for someone whose death is not reasonably predictable, then that person is in a different situation, and some people are more vulnerable than others and need more protection. So, but then if reasonably foreseeable death is not the right wording, it isn't a proper criterion. In fact, it is no longer a criterion, but it's been brought in kind of by the back door, as you have said. What would you like to see as wording there?
Basically, if someone meets the conditions for MAID, then that should be full stop. And then we would be able to proceed with MAID. Why are we adding extra conditions to people who've already met all the conditions for obtaining MAID? We think it's a paternalistic approach, and it doesn't have a legal base to justify that, to justify why we would not grant MAID. We understand that the legislature has to determine the conditions for free and informed consent. So the legislature has to determine that. And if that's the case, when we're talking about terminal phases of life, there's no problem. Quebec has 5 years of experience with this. We have set up the request for MAID within end-of-life care. And normally this should take place within the palliative care context, but that's not always the case. In fact, I'll put a question to Mr. Bureau on that. But having said that, when we're not at a terminal phase in life, perhaps we're at terminal phase with the illness or not. So how can we determine when we're talking about mental illness whether the patient has the capacity to give free and informed consent, which is not actually a manifestation of a symptom? Well, that's why we have to assess them. With each case, the physician will make an assessment. You have to understand what I'm saying. In the majority of cases, when mental illness is the dominant aspect, we will perhaps be much more careful and we won't give them such easy access to this. But a priori, there's no reason which would oblige someone right away, or rather eliminate this person right away from obtaining MAID. But we would need to take more precautions with someone suffering from mental illness. But we don't think it's acceptable to have a complete prohibition. Now I'd like to turn to Mr. Bureau. Medical assistance in dying. Quebec didn't put the MAID request, euthanasia versus palliative care. Rather, people were afraid that if we liberalise or allowed access to MAID, then there was a fear that we would give less and less resources to palliative care. There really is a problem of accessibility to palliative care. And after 5 years in the Commission, do you know that there are certain care units in hospitals that do not admit patients into palliative care where there's complete accompaniment to death because they've made a MAID request, for medical assistance in dying? Is that acceptable? Well, we said earlier that MAID is part of a process that starts, first of all, with palliative care in various establishments. And specifically, there are institutions that are private or semi-private who have taken the position from the outset to refer patients that ask MAID to refer them on to other facilities. For example, palliative care homes. Almost all of them refuse to admit these patients, but now half of the 35 grant MAID, and this movement is changing. But it's true that at the outset there was a position that there was MAID on one side and palliative care on the other side. But that has really changed now, 5 years on. So we could have a discussion on that, I think, because this is still the case. Thank you, Mr. Thériault.
We have to move on now to Mr. Garrison for 6 minutes. Mr. Garrison, please go ahead. The floor is yours.
Thank you very much, Madam Chair, and I want to thank all the witnesses for appearing today. A particular strength of this panel, I think, is the experience on the panel with what actually happens in the provision of medical assistance in dying. And my concern is too often we've had discussions that are theoretical and sometimes aren't really grounded in reality. So I want to thank Dr. Green, who on behalf of the Association of MAID Assessors and Providers has shared time with me earlier to help me understand what actually happens. So two things that have actually been raised today that cause me concern are the allegation that some people have been coerced into requesting medical assistance to dying, and the question that's been raised about some people might have transient desires to seek medical assistance to dying. I'd like to ask Dr. Green to comment on the actual experience with those two issues.
Thank you for the question, Madam Chair. I think the issue of coercion has been raised many times by many people, and there's a lot of different ways to answer that question. But ultimately, what you're asking myself and my colleagues is whether we know how to do our job. And I know that seems very personalized, but the truth is physicians, clinicians, nurse practitioners, healthcare workers, we make decisions about capacity and levels of coercion every single day in our office, every single time we see a patient, every single time we offer them a medication or a surgical treatment or any treatment at all. We need to make sure that the patient is aware of the information about, so they understand their situation and their treatment options and the pros and cons of those treatment options, and that if they seek our guidance, we can do so. But ultimately, the decision has to be the patient, which is not always the same as what I might guide them or what their family might guide them. But the patient's autonomy is essential, and we're very, very well skilled in making those determinations. Certainly, all of my colleagues, the standard of care is to meet with the patient at least once, if not more times, privately to ensure that there's no one coercing the patient in any subtle or external way. So coercion is something we're very, very aware of. Thank you for that. In terms of the concept of transient suicidality, it's a term I've never heard before this committee sat. I find it interesting. Certainly my experience, and it's very well versed coming from British Columbia, is that the patients I see have spent many, many weeks, months, and often years thinking about this issue. This is not a snap decision for anybody. And the idea that they're having a transient thought that will allow them to proceed to MAID is, I think, insulting to the patient, to their process, to their decision-making ability, and as well as to the ability of assessors and providers. We certainly recognize what we call adjustment disorders. Somebody's had a ski accident and become paralyzed. Nobody's going to offer them MAID within that week. That's absurd. And we're very well aware of these issues.
Thank you for that, Dr. Green. Two things which I think from the point of view of my constituents are very important in this bill is the elimination of the 10-day reflection period and the waiver of final consent. And can you just tell us a little bit more? I know there will be stuff in your submission, but I think these are two reasons why this legislation is urgent, and I'd like you to talk about your experience with those two.
Yes, thank you for the question, Madam Chair. I think the issue of the 10-day reflection period, as I alluded to, has proven itself to be more problematic than helpful. I come from a region of the country that has the most percentage of assisted dying in the province, in the country, and in fact in the world. And that data set has clearly showed that not just a significant portion are expedited within 10 days because patients are coming too late for care for a multitude of reasons. But what's most interesting to me is as we look at all the provisions over the last 4.5 years, the single day that has the most number of provisions done is day 11. It's striking on the data that I've sent you. It's clearly people who've been waiting for 10 days to be done. And on the stroke of midnight, they're going ahead on the 11th day, showing that they've simply been waiting. This is not a 10-day period for these people. It's been weeks, months, or years, and they're just waiting for that reflection period to be over. So I think that's striking. I've already forgotten what the second comment about the amendment to allow people to proceed if their death is reasonably foreseeable and they've lost capacity. I think Audrey Parker has made a sensation in the national media about why this is important. Certainly my experience is that the public vastly supports this. The patients and the families I've dealt with feel very, very strongly that this is a horrible situation to find themselves in. I have personally found myself in that situation. It is probably the hardest moment of my 4.5 years when a patient has gone through the rigorous process, the rigorous procedures, the rigorous safeguards, and done everything right, finally found a care provider, finally filled out the forms, finally been found eligible, and then for me to turn up at a specified day and hour and find them unable to give consent is just horrible for the family, who then feels they've let their loved one down, and that we cannot proceed, of course. So I think this amendment is timely, needed, and will be extremely welcomed by many.
And in your experience, I know I have heard anecdotally and had personal experience with people choosing to go earlier than they might have had to go because of their fear of loss of capacity. So is this something that we find in the practice of medical assistance?
This is a real concern. Thank you for the question, Madam Chair. This is a real concern amongst patients and their families, even after years of experience, even after I can tell patients that there's no reason to believe they should stop their pain medications, that there's no reason to believe they're going to lose capacity. I can reassure them as much as I want. People and their families are still terrified of this possibility, and they will often receive subpar care during those 10 days while they're waiting for fear of loss of capacity. It is the number one fear of people after they've been told they're eligible, the fear that they might lose the choice still.
Just quickly, on 30 seconds left, on the question of conscience for physicians, can you talk about the possible impacts of failures to refer on people accessing the service for medical assistance in dying?
Yeah, thank you for the question. Madam Chair, I think it's important to point out that Bill C-14 and C-7 are very clear about protecting, respecting, and supporting conscious rights. And certainly our organization is very strong in support of that. But what we do find is that when people do not follow professional guidelines to do effective referrals, we're finding obstruction of access to care. So what's happening is that patients and families are coming to us very late on, and that's where we get into the problem with the 10-day waiting and the loss of capacity. They come to us in a much more urgent situation. Many of our patients are socially isolated. They may have been hospitalized for weeks. They may not have social friends or even the technical abilities to find access to care, and they are absolutely reliant on their caregivers to provide that information and a way for them to access better information and access to care. Without that possibility, they are simply locked out of this.
Thank you, Dr.
Thank you very much. Thank you, Dr. Green, and thank you, Mr. Garrison. With 3 minutes left with this hour, I think it's time for us to thank our witnesses, and to all of the witnesses, if you have any additional clarification or any additional information that you would like to provide the committee based on what you've heard today, based on the lines of questionings from members, please do submit them to the clerk. We look forward to reviewing your evidence that you're providing. Thank you for taking the time to appear before us and to give your remarks. We'll now suspend for a few minutes as we switch between the two panels. Thank you, everyone, once again. departments of neurology, psychiatry, and medicine at McGill University. We have Dr. Mona Gupta, who is a psychiatrist and associate professor. And we have Dr. Leonie Herx, who is a palliative medicine consultant. We also have the Center of Addiction and Mental Health, Dr. Tariq Raji. Thank you for appearing with us today. Each of you will have 5 minutes to give your opening statements. We'll start with you, Dr. Gauthier. Please go ahead. Your time starts now.
Merci, Madame.
Thank you, Madam Chair. I want to thank you for this invitation. I hope that my experience as a clinician and researcher on Alzheimer's, 35 years experience in that area, will be useful for your review of the legislation. I want to make some introductory remarks, and then I'll be happy to answer any questions that you have. I want to say first that over the past few years, a number of people in the early stages of Alzheimer's have spontaneously expressed their desire for a peaceful death with their families by their side and at a time predetermined by them. For example, an 84-year-old woman wrote a document, and I just want to read you an excerpt from it. She said that if medical assistance in dying is added to the possibility to have advanced directives, I want, and I am of sound mind at this point, to add to the list of what I would like to see that when the time comes that I don't recognize my husband and my daughter-in-law, I want to have medically assisted death to respect my dignity. The point I'm trying to make here is that people think well ahead, years ahead, when they have Alzheimer's, which could be also the case for Parkinson's disease, that there will come a time when they no longer want to live. There are stages in Alzheimer's disease that are quite predictable in their sequence and their irreversibility. For example, urinary incontinence at night, if it is not caused by an infection or some other disease, is a recognized stage. It's stage 6A on a scale of 7. So people affected and their families, if they wish to be, are aware of these stages. This is information that is usually provided when people ask for it. And these stages take about 6 to 8 years until a natural death occurs through a third aspiration pneumonia after someone is immobilized in bed for a year or so. And it is in that last stage of dementia, people have been bedridden for a year or so and not communicating with anyone. So what I would like to suggest to the committee is that the current draft of the bill talks about dates chosen by the person requesting a medically assisted death, but for neurodegenerative diseases like Alzheimer's or Parkinson's, there should also be the inclusion of wording around stages. These stages that will be recognized by clinicians and family members. So I would like to suggest disease stage be added as well as the dates that are there in the legislation. Thank you.
Thank you very much for that, Dr. Gauthier. You spared us a whole minute, and we really appreciate that. Thank you. Now we'll move on to Dr. Mona Gupta. You have 5 minutes, Doctor. Please go ahead.
Thank you, Madam Chair, and members of the committee for the opportunity to meet with you today. I will shorten this to MAID for mental disorders. I'm a psychiatrist and an associate professor at the Université de Montréal. In my clinical practice, I work in consultation liaison psychiatry, which involves the psychiatric care of the medically ill. I'm a researcher in ethics and philosophy of psychiatry, and I've been working on assisted dying for the last several years. And I did serve on the Council of Canadian Academies working group on MAID for mental disorders as the sole underlying medical condition. As a psychiatrist in Quebec, I'm a member of the Association des Médecins Psychiatres du Québec, the AMPQ, which represents the province's 1,200 psychiatrists. Currently, I am chair of its advisory committee on MAID for mental disorders. This committee includes 5 psychiatrists with divergent views about the topic, a patient partner, and a family member. The committee has worked over the last 9 months to produce an advisory document laying out an approach to thinking about the difficult clinical questions that can arise in the context of a person requesting MAID for a mental disorder. We've just finished it. I've sent
Dr.
the French
Gupta,
version. Yes.
I'm so sorry. You're speaking very, very fast, and interpretation is having a little bit of difficulty pacing themselves. If you can just slow down your pace a little bit. Thank you.
Yes, absolutely. I will try. I've sent the French version of the report to the clerk, and I will be able to send you the English version at the beginning of next week. Our committee's work illustrates that professionals working with patients and families are able to come together and agree on standards and safeguards for MAID for mental disorders. Of course, there will be people who disagree. Indeed, in a survey of our own members, while 54% of respondents replied that MAID for mental disorders is permissible in certain circumstances, 36% disagreed. There will also be those who object on conscience grounds, but this is the case already. In the course of doing this work, we explored the issues of assessing capacity, incurability, irreversibility, suffering, and suicidality. Today, I'm going to speak specifically about capacity and incurability, irreversibility, as these are identified in the Charter Statement as the reasons why mental illnesses can be excluded as a basis for MAID access. First, a quick word about language. Bill C-7 uses the expression mental illness, while standard psychiatric language is mental disorder. It's unclear if mental illness is a synonym for mental disorder or if it refers to a subgroup of conditions. If it's a subgroup, we don't know which conditions are included and which are excluded. In either case, in thinking about the exclusion clause for mental illness, we are confronted by the fact that neither the Canadian nor the Quebec laws permitting MAID ever excluded persons with mental illness or disorder, nor did they make any reference to diagnosis at all. The eligibility criteria are based on the clinical circumstances of the requester. Furthermore, those who have conditions with both psychiatric and physical aspects and those who have comorbid mental and physical conditions have never been excluded, nor will they be by C7, even if the psychiatric condition motivates the request. So any rationale to exclude people whose mental disorder is their sole underlying medical condition needs to apply to this and only this group of people. The government stated rationale is that screening for decision-making capacity is particularly difficult and subject to a high degree of error, and that mental illness is generally less predictable than physical illness in terms of the course the illness will take over time. I want to point out 2 things about the worry about assessing capacity. If assessing capacity is difficult for people with mental illnesses, then the same difficulty ought to apply in cases of mental and physical comorbidity. There is nothing about the existence of a second physical condition that would remove this difficulty. If anything, it makes the situation more complex. And in fact, at present, we do assess capacity to consent to MAID in people with mental disorders and comorbid physical conditions. So presumably, if the method works in one circumstance, we would need a specific reason that shows it does not work in the other. The second worry is that we might make mistakes in our assessment of capacity, but this is not the right way to frame the problem. Capacity is not something you get right or wrong. Determining whether somebody is capable is a judgment, and in matters of judgment, it's to be expected that assessors may not always disagree. But because capacity is not presumed for MAID and has to be established, if assessors cannot agree, then they cannot proceed. Regarding predictions of incurability and irreversibility, it's tempting to say that because of the finality of MAID, we should not act until we are 100% certain. But outside the context in which a person's natural death is reasonably foreseeable, prognostication becomes more difficult in many situations. This is not limited to situations of mental disorder. The proper clinical question is how much certainty is required in order to find someone eligible. Reflecting on cases of people with comorbid physical and psychiatric conditions who have access MAID in this country reveals that the concerns raised about assessing capacity and prognosis are already part of current practice. I've explained this with some real case examples in a short document that I've sent to the clerk. In conclusion, I don't think there's a way of distinguishing all cases of mental illness as a sole underlying medical condition from other clinical problems for which MAID is permitted that withstands logical scrutiny. As a result, what the exclusion clause will do is show that it is acceptable to treat people with mental illnesses differently than others. The AMPQ does not accept this position. We believe our patients must be entitled to exercise the same rights as all other persons. Thank you.
Thank you very much for that, Dr. Gupta. We'll now move on to Dr. Leonie Hertz.
Point d'ordre, Madame la Présidente.
Oui.
Point of order from Mr. Thériault. Yes. Well, I was saying point of order. The translation was continuing. I would really like you to recall to the witnesses that they need to slow down because it's not intelligible when it's so fast. And it creates a phenomenal amount of work for interpreters. So I'd really appreciate if you could intervene. It's deplorable that we only have 5 minutes to listen to these high-quality witnesses and everything they have to say. But as there are briefs that are submitted, we need to try and promote communication. And sorry for having taken up time there.
You're absolutely right, Monsieur Thériault. Thank you for your important intervention. I've been trying to make sure that we're getting as much as possible, but we'll continue to try harder. So I will ask now Dr. Leonie Hertz if you can please commence your 5 minutes. And for the benefit of interpretation, if you can please go as moderately paced as possible. Thank you.
Thank you, Madam Chair, and thank you to the committee for having me today. Good afternoon. My name is Dr. Leonie Hertz. I'm a palliative medicine specialist, associate professor, and head of palliative care at Queen's University. I'm the immediate past president of the Canadian Society of Palliative Care Physicians, and I've been on their board of directors for the past 8 years. I'm also an advisor to the Vulnerable Persons Standard, an internationally recognized evidence-based framework that outlines the safeguards necessary in a system for medically administered death to protect vulnerable persons who may be subject to coercion and abuse. I come before you today to share concerns that are not mine alone, but are shared by many physicians across Canada, evidenced by the 959 and counting physicians from all medical specialties who have signed our Made to Mad petition that was submitted to this committee. In the Carter versus Canada ruling, the Supreme Court stated that a carefully designed and monitored system of safeguards would limit risk to vulnerable persons. In our recent publication in the World Medical Journal in April 2020, my palliative medicine colleagues and I documented concerns and reviewed evidence of errors and harm occurring under the current C14 MAID regime. A copy of our paper has been submitted to you as well. C7 proposes to further reduce these safeguards and put more Canadians at risk of wrongful death. Year after year, there have been documented cases of non-compliance and misapplication of the law and policy with respect to MAID in Canada. The Chief Coroner of Ontario, the End of Life Care Commission in Quebec, and very recently, the Correctional Investigator of Canada have all reported on these issues. We also see instances of vulnerable patients being told by the healthcare team that they should consider a medically administered death because the cost of their care is too great. Roger Foley from London, Ontario, required 24-hour care that was not able to be provided in his home. While living at the hospital, an administrator suggested that he get MAID not out of compassion for his circumstances, but out of concern for the cost of his care on the system. This conversation was recorded and, of course, has been widely shared. MAID has also been suggested when the healthcare team perceives an individual as not having value. Candice Lewis, the 25-year-old woman with a developmental disability, chronic medical problems, while receiving emergency treatment in hospital, when a doctor approached her mother, suggested that she consider MAID for her daughter. Her mother said they were not interested in MAID, and the doctor told her she was being selfish. The doctor then tried to convince Candice herself that she should get MAID, and because Candice felt scared, she asked to go home. The family complied and took her home, also feeling that it was unsafe to stay in the hospital. The UN Special Rapporteur on the Rights of Persons with Disabilities issued concern after a recent trip to Canada in 2019, stating that she was extremely concerned about the implementation of the legislation on medical assistance in dying from a disability perspective, and that there was a lack of protocol to demonstrate that persons with disabilities had been provided with viable alternatives when eligible for assisted dying. We have seen countless patients whose hope and resilience were restored when they had their basic care needs met. We know that many people requested medically administered death out of fear of being a burden to others. This sense of being a burden and demoralization is amplified when real options to support living do not exist. If we are trying to make a medically administered death regime safer for Canadians, then we should look to the Victoria, Australia legislation, which employs stringent safeguards to address important issues such as the risks of coercion. I've included sections of the legislation in my written brief for your reference. In the Victoria legislation, doctors must not bring up assisted death to a patient unless they ask about it. This is especially important for persons who already feel a burden and less valued in society due to systemic discrimination. Bill C7 is written in such a way that a patient could choose to die before they have actually received therapies that we know in medicine have a high likelihood for recovery or relief of suffering. In other countries where MAID is legalized, it is most often only available for those who are dying. Regardless, all other jurisdictions require that physicians determine that there are no other options of care left to pursue as a last resort only. Physicians who know that there are reasonable treatment options for their patients have a professional duty to instill hope and support resilience and not to stimulate a desire to die. My professional integrity as a physician compels me to offer recommendations to promote the health and well-being of my patients. If I am required to present death as an option alongside evidence-based standards of medical care, this compromises my ability to provide good care to my patients. Doctors need to be able to work with integrity and have our conscience rights respected. For the sake of vulnerable Canadians and the practice of medicine, I urge this committee to make significant amendments to this proposed legislation. Thank you.
Thank you very much, Dr. Herx. You were exactly on that 5-minute dot. Really, really appreciated. And then last but not least, we'll go to Dr. Tariq Raji from the Center of Addiction and Mental Health. Please go ahead, doctor. You have 5 minutes starting now.
Thank you, members of the Standing Committee on Justice and Human Rights. Thank you for the opportunity to appear before you to discuss Bill C7 and specifically the amendment that persons whose sole underlying medical condition is mental illness are not eligible for MAID. My name is Tariq Raji. I'm a psychiatrist. I'm the chief of the Adult Neurodevelopment and Geriatric Psychiatry at CAMH at the Center for Addiction and Mental Health in Toronto. CAMH is Canada's largest mental health teaching hospital and one of the largest leading research centers in the field. CAMH uses its expertise in clinical care, research, education, and system building to improve the lives of people impacted by mental illness, including those with substance use disorders. Since 2015, a working group of CAMH staff with expertise in psychiatry, social work, law, ethics, public policy, and lived experience have been deliberating regularly on MAID and mental illness. It is our collective expert opinion that Bill C7 gets it right. We agreed that there should be a temporary prohibition on MAID for those whose only medical condition is mental illness until, as the bill preamble states, further consultation and deliberation determine whether it is appropriate and, if so, how to provide MAID to persons whose sole underlying medical condition is mental illness in light of the inherent risk and complexity of the provision of MAID in those circumstances. The reason we support this temporary prohibition is that there is currently a lack of consensus in the mental health field to determine when an individual has an irremediable mental illness. To explain further, to be eligible for MAID, an individual must have a grievous and irremediable medical condition. Their illness, disease, or disability must be incurable, irreversible, and irrecoverable and cause intolerable suffering. The grievousness of an illness is subjective, and there is no doubt that some people with mental illness experience intolerable psychological and sometimes physical suffering due to their symptoms. The irremediable nature of an illness, however, is an objective determination that must be based on the best medical evidence available. CAMH concerns that there are currently no established criteria that define if and when a mental illness should be considered irremediable. That is because there is simply not enough evidence in the mental health field at this time to predict the trajectory of any one person's mental illness and to ascertain whether an individual has an irremediable mental illness. This means that the irremediable criteria would be open to interpretation by each MAID assessor, and any determination that a person has an irremediable mental illness would be inherently subjective and therefore arbitrary. This could put people with mental illness at risk of accessing MAID when they do not actually meet the eligibility criteria. Therefore, CAMH strongly recommends that evidence-based criteria be developed prior to any decision to lift the temporary prohibition on MAID for people whose only medical condition is mental illness. These criteria should establish a consensus definition for when a mental illness should be considered irremediable for the purposes of MAID, CAMH recommends that the government appoint an expert working group to develop these criteria within a reasonable time frame, recognizing the complexity of the task. The working group should develop the criteria in consultation with a broad range of experts in the mental health field, including people with lived experience of mental illness and family members. The introduction of these evidence-based criteria should be accompanied by training for MAID assessors. CAMH would be happy to participate in the development and dissemination of the criteria. Thank you again for the opportunity to speak with you today on this complex and nuanced topic, and I'm happy to answer any questions.
Thank you very much, Dr. Raji, for your concise remarks. I really appreciate it. Having exhausted the witness list, I will now go into our round of questions. The first round being 6 minutes per member. We'll start with Mr. Cooper. You have 6 minutes, sir. Your time starts now.
Great. Thank you very much, Madam Chair, and thank you to the witnesses. I'm going to address my questions to Dr. Herx, and I want to drill down into some of the safeguards that this legislation would remove, starting with the 10-day reflection period. In the letter that you signed, along with other physicians, it makes reference to the possibility of same-day death. Now, during the debate at second reading, the government dismissed that possibility, but can you elaborate on that concern with respect to the elimination of the 10-day reflection period?
Yes, thank you for the opportunity. Obviously, this is the work that I do on the front lines with patients every day who express a desire to die as part of normal grieving and anger and frustration, and sometimes despair at facing a new devastating diagnosis. And it's most often these wishes for death are fleeting and transient in nature. And in fact, Dr. Harvey Chochinov, a renowned psychiatrist in Calgary, has shown in Canada, has shown that these death wishes can be transient even as over a shorter period of time as 12 to 24 hours. And so having elimination of the 10-day waiting period doesn't allow a person time enough for reflection to change their mind. And many times we see patients change their mind when they have access to good care and supports and an ability to see their lives in a different way, to have meaning. And it's often driven out of fear and anxiety as opposed to uncontrolled physical symptoms. And so helping a person receive supports to work through their new diagnosis is very important. And so for people with a reasonably foreseeable death under this new legislation, a person could be having a really bad day and be in despair. They haven't seen a loved one. We've seen social isolation and loneliness amplified through the COVID-19 pandemic. Out of those depths of despair on their worst day, that could become their last day without a reflection period required to make sure that this is actually what a person wants and it's not a transient desire out of not having adequate supports or time to really understand what they're asking for.
Right.
So it's very important that the 10 days are upheld. And in fact, some would say it should be even longer. And Dr. Chachinov's work actually shows that that desire to die gets relinquished over about a 2-week period with proper support.
Okay, thank you for that answer. And maybe if you could just comment on the suggestion by the government that in an actual setting that if this would never happen in terms of same-day death. But before you comment on that or respond to that, which we've heard the government say in some of the debates in the House, I want to also ask you about the removal of the requirement of 2 witnesses down to 1, including now under the legislation a healthcare professional who could be a witness. Are you concerned about issues of conflicts of interest or undue influence on vulnerable patients?
Absolutely. I'm very concerned, as are many of my colleagues, about the nature of possible either subtle or overt coercion from healthcare professionals. As we've seen, and I've reported already, many persons have been suggested that they get MAID because of their circumstances. We also have instances of medical professionals involved in MAID suggesting to persons that they should get it sooner because they might lose capacity. So I already witness every day issues of coercion where professionals are suggesting to patients that they should get MAID sooner because they might miss their opportunity. So having two independent witnesses is very important to make sure that people are not being pressured by the healthcare team to choose MAID, whether it's due to lack of resources or perceived poor quality of life, as I mentioned earlier.
Thank you for that. And I would also be interested in your comments on risks associated with advanced consent.
Yeah, so it's I think very difficult to have advanced consent for MAID when a person loses capacity. They don't actually know what they're agreeing to at that time. Every week I see patients who have requested MAID and actually end up getting MAID even though they don't have capacity. And there's sometimes a disagreement between myself and a MAID assessor or provider in terms of what capacity the patient has. For example, a patient would change his mind from time to time whether he wanted to go to hospice and have a natural death where his pain was well controlled or have the needle, as he called it. And he wasn't able to differentiate between those two and would flip from one to the other even hour to hour, which is a very consistent process with something called delirium, when you're not fully comprehending and understanding what you're asking for. And so at a time when people are getting MAID through advanced directives, how do we know when they lack capacity that that's still what they want and that they still understand what they're getting? I don't think that's possible.
How much time, Madam Chair?
15 seconds.
15
Mr.
seconds.
Cooper.
Well, I guess my time's expired.
Thank you. Thank you very much for that. I will move on to now Mr. Virani for 6 minutes. Go ahead, Mr. Virani. You're on mute, sir.
Start by just saying hello to an old friend and debating colleague from McGill University. So it is nice to see you, Mona Gupta. I'll try not to call you Mona and call you Dr. Gupta in this platform. And I recollect that those of us who thought we were smart, who were debaters, went to law school, and those of us who were actually smart went to medical school. So we know which category you firmly fit into. But true to form, Dr. Gupta, you've actually teased out some of my questions because I had a look at the charter statement. I had a look at some of your work on this issue about mental disorder or mental illness as a sole underlying condition. And you canvassed a couple of points that are raised in the charter statement, but there's a few others that I want to put to you. I'll invite Dr. Raji to also comment. Other components as to why.
Sorry, Mr. Virani, can you please move your mic closer to
yes,
your mouth?
I apologize about that. Other components as to or considerations that were put into why we excluded mental illness was one is that the exclusion is not outright. You know that it can be coupled, as you mentioned in your comments, with some other disorder or condition. Two is that this issue has actually been legislated in Belgium, Netherlands, and Luxembourg, and we've seen rising cases of medical assisted dying in those jurisdictions, including in some areas that seem fairly gray to neutral observers. And the third point is that this is just me as a layperson. There's many more laypersons than doctors in this committee who understand that when suicidal ideation, contemplating suicide, is just a manifestation of a condition, does that necessarily need to nuance our approach to mental illness as mental illness or mental disorder as mental disorder? So if you could comment on those three aspects, and then I'll ask Dr. Raji perhaps to comment as well. Thank you, Dr. Gupta.
Thank you very much, Madam Chair, and thank you, Mr. Virani, for the question. So I think part of what motivated what I was trying to bring to the committee today is the fact that people that have mental disorders and physical disorders can access medical assistance in dying now, have already accessed medical assistance in dying, and that these types of clinical situations raise exactly the same kinds of concerns that the government indicates in its charter document. So if we're able to assess capacity now, if we're able to assess irremediability now in cases of medical and physical comorbidity, it's not clear to me why we wouldn't be able to do it in cases where a mental illness is the sole underlying medical condition. So in order to nuance, I think, an exclusion, if that's the government's wish, there has to be a characteristic that is really unique to that group of people, but clinically, I don't think there is one. As for the experience of assisted dying in the Benelux countries, This remains a marginal practice relative to the practice of what is called their euthanasia and assisted suicide. A rise in number of cases in and of itself, I think, does not suggest any phenomenon one way or the other. Cases of assisted in dying in general rise over time. That's something that we've seen in our own jurisdiction. That's something that the Commission Soins de Fin de Vie has documented since they began keeping data in 2015. So in and of itself, a rise doesn't tell me anything specific. The fact is that it remains a marginal practice. And in Belgium in particular, in fact, the cases have declined over the last 4 years. So, but the practice is so marginal and the case numbers are so small that I don't think these small increases and decreases in either direction really tell us very much. As to the last point about suicidal ideation, I mean, and this is something that's come up a lot in this debate, and I think this is a very fair point. Every day in psychiatry, we meet people that have suicidal ideas. And every day in the course of clinical care, we have patients who have mental disorders and who also have physical disorders, who have to make high stakes clinical decisions that could even be life-threatening decisions. And they may have been suicidal in the past. They may have made suicide attempts in the past. And so clinically, our role is to see if the person is capable of making that decision now, is to try to understand their suicidal thinking over time and over the trajectory of their illness. So that's something that we do now, and that's something that we will have to continue to do. But I think, and you'll see this when you receive our document from Quebec, the idea that someone's going to come to emergency room in an acute crisis because an end of relationship and they have suicidal thoughts and that they're going to access and receive MAID on that day is not what we have in mind by a structured and rigorous practice in which we're talking about people who have suffered over decades and have really had access to a very complete armamentarium of available treatments. So we're not talking suicidality.
Thank you very much, Dr. Gupta. I just want to add Dr. Raji into this conversation, but I also note that you yourself, as a member of the Canadian Council of Academies, that preliminary report itself was not conclusive on this. So he suggested sort of further study on this. So Dr. Raji, if you could comment on that, and Dr. Gupta, if you could just say in 10 seconds whether you agree that this should be put off to the further parliamentary review or not. Dr. Raji?
We may have, oh, can you please unmute yourself, Dr. Raji?
Sorry about that. I just wanted to clarify, Mr. Brand, do you want me to comment on the question of further studying or on all the points that you raised before?
A little bit of both, but I appreciate your time is pressed, but the further study point as well as the other points that I raised. Thank you.
Right. So
very briefly, Dr. Raji, we're very, very short on time. Thank you.
So I want to underscore the fact that there is no consensus in our field about how do we define a remediable mental illness. So I think that that's and the fact that there are different opinions and strong different opinions speaks to the fact that there is no consensus. And that's what the CCA, after a month of deliberation, concluded. I think the point I was making in my presentation is that a remediable nature of this need to be based on evidence of the scientific evidence. And when we talk about some of the most severe conditions in mental illnesses, like psychotic illnesses, and when long-term studies show that up to 30% of people go into recovery long-term from these conditions, that's not a minority, and that tells us about the weakness in our field in predicting the trajectory at the individual level.
Thank you very much, Dr. Raji. Mr. Virani, unfortunately, we're out of time for you. We'll move on to Monsieur Thériault for 6 minutes.
And you now have 6 minutes, Mr. Thériault. Thank you very much, Madam Chair. And thank you to all of the witnesses. These have been very informative. Dr. Gauthier, you have told us that you have 35 years of practice. And you have talked in the light of your clinical experience, and you've referred to neurodegenerative illnesses, and you've said that you're able to identify when it's possible to free and informed consent that is valid beyond any reasonable doubt. You have referred to various stages in the development of the disease. Could you please explain to us now why, according to practice, it's possible to establish this point in time where there's free and informed consent when we're dealing with cognitive neurodegenerative diseases? Thank you very much for your question through the chairwoman. With certain neurological diseases, there are clinical stages that are well identified, well known, which stretch over several years. At the beginning with these diseases, people are invited to plan in advance in terms of their financial matters, their personal matters, and MAID, medical assistance in dying, will soon be part of that planning process. Now, it's certain that it's only in a few years that we'll be able to see if we can actually operationalize the choice that a person has made 5 years ago. Namely, the lady of 84 years of age who was very lucid, as you've seen in the text, because of her level of education. It was a very structured declaration that she made, and she chose a stage that's going to occur in 4 or 5 years' time. For the needs of the committee, I would like to ask you to add in this notion of the stage of the illness as part of MAID without going into details, because of course for each disease there will be different stages involved, and in the years to come there may be new treatments that will actually change the progression of the disease, but what will not change is that there are certain milestones with most of these diseases. For example, loss of mobility, the first pneumonia. Certain things will not change even if we make therapeutic progress. You've referred to different stages. So to which stage will it be possible to establish an advance directive or an advance request?
Because you take for granted that today people are familiar with these stages in Alzheimer's disease, and you wrote a remarkable book about that. So I would like you to give a little bit more detail about what stage would be appropriate, given your experience, on when an advance directive should be used. Yes, thank you, and through the chair. The usual stage when we asked people to write down directives with their family and before notary is when they can give specific instructions on their choices, on the disposal, the disposition of their good. They make these choices at the beginning of the diagnosis, and this would be at stage 3 out of 7, where there is slight cognitive impairment and that Alzheimer's or dementia has been identified as the cause. And then at stage 4 of 7, people can still drive their car, but they have to stick to familiar areas. They might have difficulty with more complex financial transactions, but can function fairly well. So it would be at stages 3 or 4 that they would make these directives. Thank you. That's interesting. With respect to mental illness as a sole criterion for MAID and for exclusion of that possibility, the more I hear about the complexities of this, the more I feel I need to study it further. First of all, there are differences between mental illnesses like schizophrenia and dementia, so we can't look at all cognitive problems the same way. And then we have a responsibility as legislators to establish, without any doubt, the validity of free and informed consent. And so from what I've heard up to now, it is not possible to go ahead with this possibility right now for mental illness as the sole criterion. So we need to think about this not in a few years, but right now. And certainly we could take into account these neurodegenerative diseases that you are talking about, Dr. Gauthier. That's all I have to say. Thank you.
Monsieur Thériault, merci.
Thank you, Mr. Thériault.
We'll now move on to Mr. Garrison for 6 minutes. Apologies. Go ahead, Mr. Garrison.
Thank you very much, Madam Chair. And I want to start by thanking the witnesses for appearing today and stress that I respect the expertise that each brings to this question. In their testimony today, they've raised many issues that I believe need to be dealt with in the broader review, the statutory review that was required. And I just want to say I'm hopeful that amongst the parties, we can soon reach agreement about the mandate and timing for that general review to take place. I do want to put two concerns on the record here, Madam Chair, before I ask my question. One, I think it's important that members of the committee distinguish between those who have actually worked as MAID assessors and providers and those who have not. My second concern that I wish to raise is even more serious. I am always concerned when witnesses appear before the committee under the protection of parliamentary immunities and make accusations about other individuals that amount to, in this case, allegations of malpractice. And I think we have to be very careful when we listen to the testimony of those who've made such accusations, rather than referring those cases to professional bodies or to the police if that's appropriate. And those who make those accusations, I think we should seriously consider all the testimony they've given, given the what I would call unethical testimony that we've heard from at least one witness today. So now I want to turn to something more positive, and I want to thank Dr. Raji for his very constructive suggestion on the question of how we deal as a committee in this legislation with the concept of mental illness as an underlying condition. And I'd just like to ask Dr. Raji how big a task he thinks it is to have a working group which would establish evidence-based criteria. How long would that take, and how large an undertaking is that?
So guys, thank you for this question. It is a complex task. It's not a small task, and I think it will have to take, in my mind, as long as it needs to take. The complexity and the implications and the strong different opinions play into the timing for this test. But I think the group has to be quite diverse. It has to include the professionals and the psychiatrists and the other mental health professionals that such an amendment is actually affecting their practice, and it's addressing, it is touching so some of the core issues in their field, which is understanding the concept of suicide and what is suicide? What does it mean to have suicide when someone is asking to receive MAID? If are they asking for suicide or not? It has to also include family members. It has to include the people with lived experience themselves. It has to include the other professionals who are, quote unquote, we call them allied health professionals, who may not be the most responsible clinician, but also are affected by this practice, and other maybe other stakeholders. So, but I think without getting into, without reaching a consensus about the definition of the remediable criteria, it will be very hard to apply this criteria if we don't know how to define it.
Thank you, Dr. Raji. Can I ask Dr. Gupta her reaction to this suggestion of an expert working group?
I mean, there's no harm in spending more time thinking about these issues. They are complicated issues. I think a lot of work has already been done on these questions. And I think that if we look at countries where this practice is permitted, the lack of consensus doesn't go away. So we can continue to study. I don't know that we're going to learn a lot more that's new. And I think we are actually already assessing irremediability in the context of mental disorder. We're just doing it with patients who have other conditions as well. And so I think we can learn from those experiences to help inform the practice with people who have a mental disorder and no other condition. But these complex cases are already being assessed and people have already access made as a result. So I think that the exclusion criteria will just prevent a very small number of people from having access.
So your advice would be that it would be safe to remove this prohibition on mental illness as the sole underlying condition, but also that we could study this further at the same time.
Or another alternative would be to say, look, there are some really specific safeguards and best practices that we want to get right in this area, and we want to give ourselves that time to do it, but let's discipline ourselves and put a deadline on that exclusion clause so that it can't be indefinite. And so that we say, well, if this is really what we want to do, then let's be focused on that task, and let's ensure that at the same time we respect wishes, as Bernard pointed out, of individuals on a case-by-case basis according to their clinical circumstances, which is what both laws always required for every other patient.
Thank you. Dr. Raji, would you agree with Dr. Gupta that we could remove this provision while we're still studying it without great risk?
No, I don't agree with this because the specific point here is that we're trying to we're asking assessors and clinicians to apply a criterion during the assessment that has not been defined in mental illness. So I think it's the same way as when we talk about the age criteria, we talk about the capacity criteria. There are definitions. These have been well defined. However, we have not defined what does it mean to have an irremediable mental illness. So I don't agree that we don't go with the amendment before agreeing as a society on the definition of irremediable mental illness.
Thank you, Dr. Raji.
Thank you very much for that. And just seeing that we have 10 minutes left for questions, I will allow, instead of doing a full round at my discretion, to give 2 minutes per whichever speakers I have next to ask any questions that you'd like. So I have Mr. Lake, Mr. Kellaway, Mr. Theriault, and Mr. Garrison for 2 minutes each. If you can please stick to that timing, that would be great. So go ahead, Mr. Lake, you have 2 minutes.
That seems like a strange decision to make, but you're the chair. Because I had a lot to say. First off, I can't believe how fast this committee is studying this. This is just, to me, it's unbelievable that you're racing. It was interesting to hear the witnesses, every one of them having to be cautioned against going too fast because they all had so much to say. And for some reason, we're racing against time on one of the most complex issues that I've seen in my 15 years as a member of Parliament. Listening to Ms. Herx's story about Candace was just heartbreaking. I have a 25-year-old son with autism, and I'm trying to get an understanding. Had some questions. Not going to possibly get an answer in 2 minutes to the questions I was prepared to have more time for, regarding how someone with a developmental disability would even indicate what the criteria would be for their capacity to indicate their willingness to choose medical assistance in dying. Rarely do I see unanimity in the disability sector, but there's almost unanimity in the fact that this is moving ahead way too fast, and that there are way too few protections for people with disabilities. And I guess in the 40 seconds that are left in my time, maybe someone could give a comprehensive answer. Maybe Ms. Herx could give a comprehensive answer to that, because that's how long we have to study something this important.
Thank you very much for your comments, Mr. Lake. Dr. Herx, you have 30 seconds. Go ahead.
As I don't think it's be possible to address
that's completely insane.
And Dr. Herx, what I would recommend is that if you're able to please provide written remarks to the committee with respect to the questions that have been raised by Mr. Lake, if that's possible. And that is obviously open to all witnesses on the committee to please provide written clarifications or written answers if something has been missed. Thank you very much for that, Mr. Lake. Now we'll go to Mr. Kellaway for 2 minutes. Go ahead, Mr. Kellaway.
Point of order.
Yes, Mr. Moore?
Madam Chair, you didn't let her answer the question. She had 30 seconds and then you spoke for 30 seconds. Please number one, we agreed on a timing for these committee meetings, and we are in a 5-minute conservative slot. So the witness has 30 seconds to answer. You can't filibuster her answer. So could we please allow 30 seconds for Mrs. Hertz to answer?
For clarification, Mr. Moore, Dr. Hertz had said that she would not be able to answer in those 30 seconds. And so I had clarified for her that she is able to give a fulsome and wholesome answer by writing into the committee so that she's not rushed with respect to providing whatever comments that she has to make. And I'll stick to that ruling. Thank you for raising that flag, Mr. Moore. Go ahead, Mr. Kellaway.
Thanks, Madam Chair, and I want to extend a warm
Point of order.
Yes, Mr. Moore.
Madam Chair, we are in a 5-minute conservative time slot. Just because it happens to be that the meeting is going to end when it's conservatives' turn to speak, Mr. Lake has 5 minutes to ask this witness or any witness the questions. You can't just make things up as we go along. We've agreed as a committee that this is a 5-minute spot, and divvying it up that's not how these committees work.
Thank you for raising your concerns, Mr. Moore. We do try to operate as flexibly, obviously, given the committee room times, but I take your point. So I'll ask Mr. Clerk, how much longer do we have this room for to ensure that we're able to get through all of the questions with the time that we have?
Madam Chair, I believe that if the committee goes a little bit beyond one, it would be okay. Thank you.
Okay. Thank you very much. And thank you, Mr. Moore, for your very kind intervention. Mr. Lake, I believe you now have the opportunity to ask your 5 minutes of questions, of which 2 you've taken, so you have 3.
I believe I only took a minute and a half, and then the witness gave up the other 30
Please
seconds. So my question to Ms. Hertz stands. What would be the criteria for someone with a developmental disability to determine capacity for them to indicate that they want medical assistance in dying?
I think that's a very complicated issue, Mr. Lake. It would take a consultation with a capacity assessment expert and specialists who are familiar with young adults with disabilities to be able to really spend a large amount of time would be required to really understand how to best communicate with this person, what level of understanding they have about their unique circumstances and what their treatment options are. And I can say that as the stakes get higher for decisions, such as a termination of a person's life, I don't think it gets any higher than that. The amount of time it takes to assess capacity needs to be equal to that. So I know, the head of the complex capacity assessments at McGill University has told me that in her most complex cases, they take several hours to really understand the person's capacity. And so it's a very complicated situation that most MAID assessors do not have formal capacity training, at least in my experience. And I know that's the same experience that my colleague at McGill has expressed, that even when we've asked for psychiatry to be consulted in these complex cases, it's not always happening. In fact, I can give examples that I've experienced where I've actually recommended capacity assessment because I didn't feel this person had medical decision-making abilities, and that was not followed. I even documented in the medical record and raised my concern with the MAID team, but that person went ahead and got MAID anyway. And I was told that they do their own assessments for capacity. So I think it's very complicated, and we should really be relying on experts when it comes to a matter of life and death. Thank you.
Ms. Gupta, the disability community and many in the developmental disability community specifically have raised significant concerns about this issue. The fact that these changes are being made very quickly and that there are very few protections for people with developmental disabilities. Do you think that those concerns are valid? Ms. Gupta?
Certainly, yes, thank you, Madam Chair, and thank you for the question. Certainly, any group of persons who raise concerns about whether there are adequate safeguards, how a law is being implemented in practice, these are certainly to be taken seriously, and they are certainly to be considered valid and to be explored. I think the tension we really have with medical assistance in dying is that we have identifiable groups of people who may have characteristics of vulnerability or not have characteristics of vulnerability, but we also have individuals who are requesting assistance in dying, and they have their own characteristics of their own lives and their own conditions. And so I think one of the difficulties we run into is how do we make considerations and safeguards that take into consideration the vulnerabilities of groups while also respecting the lived experience and autonomy of individuals.
Thank you. Thank you very much, Dr. Gupta. I appreciate that. And we'll go on to Mr. Kellaway now for 5 minutes. Go ahead, Mr. Kellaway.
Point of order, Mrs. Chair.
It's Madam, if that's okay. I'm not a Mrs. But go ahead, Mr. Moore.
Well, Madam Chair, what are we doing here? We agree as a committee when we are going to meet. We agree as a committee, we vote as a committee of what the order of questioning is. So we are all busy people, including our witnesses. We're in a committee that's scheduled to go from 11 o'clock till 1 o'clock. It's now 1 o'clock. So why are we doing it seems to me that there's a bit of a situation where we're not willing to follow the rules unless it's going to disadvantage conservative members of parliament who are trying to ask questions and trying to do it within the rules. So we've set out as a committee the rounds of questioning, the amount of time it would take, and when our meetings end. So our meeting ends at 1 o'clock. I find it extraordinary that we come to 1 o'clock and witnesses have things to do. I have things to do. I presume the other members of parliament have things to do. But now we're somehow going into another round of questioning when the meeting's over.
Madam Chair, if I could just speak to that point.
Ahead, Mr. Virani.
I'll confess a bit of confusion because 6 minutes ago, I believe the chair was being faulted for not permitting Mr. Lake to ask his full round of questioning. You then intervened with the clerk who indicated that we have the room available. I believe and I thought that there was consensus amongst committee members and amongst the witnesses to continue so that we could conclude a full round of questioning, which is what I thought Mr. Moore was originally raising a concern about. And now it seems that the exact opposite concern is being raised. So I would ask for just some clarity, because I personally, and I believe my Liberal colleagues, believe that if people want to ask a full round of questions and if the witnesses in the room are available, we should continue so that we can do just that. Thank you.
Thank you, Mr. Virani. And before I come to you, Mr. Garrison, I will say that addressing your concerns that you had raised, Mr. Moore, at the last meeting about running over time, I had tried to divvy up whatever time was remaining to keep your schedule in mind, to make sure that we had an equitable distribution of time for all the members on the committee. And that's what I was trying to do. With your intervention and with the clerk's clarification that we do have the room for another full round of questions, I am happy to make that decision and to allow for another full round of questions. Mr. Garrison, on this point of order.
Thank you very much, Madam Chair. I think we would need unanimous consent to proceed beyond our scheduled time. And while I would very much like to hear more from the witnesses, do more questions, like everyone, we have schedules to keep. And so if I'm being asked to consent to extend the time, I would not agree.
Okay. Thank you, Mr. Garrison. And Mr. Moore?
No, we've agreed on speaking times. We've agreed the rounds. We've agreed that it goes conservative, liberal, bloc, NDP, and then back to conservative. So changing the rules as we go is not going to be conducive to us being able to have productive committee meetings. So we've heard from witnesses. We've done our rounds of questioning. It's the end of the meeting, and there's not consent to continue the meeting any longer beyond our schedule.
Thank you, Mr. Moore. My understanding is that it is not unanimous with which we proceed with whether to extend the committee or not. It is by majority. So I ask the committee now if there is a majority of the committee that would like to continue the meeting to finish the second round of questions. If you can please at this time, unless there's further debate, we'll ask the clerk to administer a vote, whether it's recorded or on division at this time. Go ahead, Mr. Clerk.
Mr. Cooper?
No.
Mr. Lake?
No.
Monsieur Thériault?
Oui.
Mr. Garrison?
No.
Mr. Kellaway?
Yep. Yes.
Yes. Mr. Lewis?
No.
Mr. Maloney?
Yes.
Mr. Moore?
No.
Mr. Sanga?
You're on mute, sir.
Yes, please.
Mr. Virani?
Yes.
Et puis Monsieur Zuberi?
Yes.
Okay, so yeas pour 6, nays contre 5, 5.
Thank you. So at this time then, we, I guess, are done with this meeting today. Mr. Clerk, if you can please send out a reminder to all the members of the committee to please sign in at least 15 to 20 minutes before the meeting starts so that we can start in a timely fashion and then continue the meeting in a timely fashion as well. Thank you, everyone. I would like to take this moment to thank our witnesses for your time today. We really appreciate, and again, I will remind you if there's things that you have not been able to get on the record today, things of clarification that you would like to provide, please do submit your written submissions to the clerk so we can get them on the record and we can include them in our deliberations of Bill C7. Thank you, everybody, for your time, and meeting stands adjourned.
Thank you.
Oh, sorry. Nope, that's fine.